Welcome everybody. Just going to give everyone a moment to get get into the webinar. Many thanks to Vishwa Ramnani, our dietitian, who's going to be presenting today on brain food. So Vishwa is one of the experts at NRC Medical Experts, and she wears a lot of other hats as well, which I'm sure she will be able to tell you all about. So I'm gonna We've got most people are coming in. We will be using the chat function during the webinar for Vishwa's quiz, and there'll be a Q&A which we'll come to at the end. So please feel free to use the chat. But if you've got a specific question, please do use the Q&A for that. So I'm going to disappear, but I'll be here in the background, and I'll hand over to Vishwa.
Hello, everybody. I hope everybody's enjoying the good spell of weather that we are having at the moment. It's a beautiful day here in Birmingham. Okay. This presentation provides a broad overview of the role of nutrition in brain injury, and it also seeks to raise awareness among solicitors, case managers, and other healthcare professionals of the role of nutrition across the continuum of care within the brain injury pathway. So my name, can we move on to the next slide, please? As you know, my name is Vishwa, and I have worked in the field of brain injury, stroke, and neuro rehab for a large part of my career. And I specialized in nutrition support for patients with neurological conditions. Next slide, please. So, quite often in real life, when I'm talking to people and say that I'm a dietitian, the immediate reaction I get is a comment on the weight or something to do with the weight. So there's a general perception that dietitians only do with weight management. So I think it would be a good idea just to kind of look at what dietitians actually do. Dietitians work across different specialisms across community, acute, and the food health industry within health and social care. They work in different specialisms, and dietitians are qualified and regulated health professionals that assess, diagnose, and treat dietary and nutritional problems at an individual and wider public health level. Dietitians interpret the science of nutrition to improve health and treat disease conditions by educating and giving practical, personalized advice to clients, patients, carers, and colleagues. Next slide, please. So before we dive into the content of brain injury and nutrition, let's just kind of have a quick couple of questions just to get our brains ticking. So if we could have the first question, please. And if you could type your answers in the chat, that would be great. So can you name the 5 taste senses in the chat? Yeah, umami is one. Perfect. Yeah, sweet, sour, salty. One more, umami. Yeah. So we've got sweet, sour, salty. Could we have the answers, please? Sweet, sour, salty, bitter, and umami. That's right. Lucia, who got it right. So umami, for those who don't know, refers to the delicious savory taste, which is kind of the meaty, savory deliciousness that deepens the flavor. So well done, Lucia, for getting that right. If we could have the next question, please. So what foods are often linked in the media for a healthy brain and improved memory? Food is a very common topic within media, so I think, but these two things keep coming up. If you could type in the chat, please. Yeah, oily fish is one. Yeah, oily fish, nuts. Oh, blackberries, fish, blueberries. Yeah, omega-3. Yeah. Well, quite often what we've come across is, and we often get asked questions about coffee and chocolate actually. Not that the other answers are wrong, but chocolate and coffee seems to do the rounds a lot as well. Okay, so if we could have the next question, please. So what is the average nutritional content of that's in terms of calories and protein of hospital meals per day? If you could type in the chat, please. So we have 600 calories, um, 2000 calories average, 1500 calories. Yeah. So, Michelle, that's right. It's around 1500 calories and 60 grams of protein. That's on an average, hospitals would provide from the meals in a day. And if we could have the next question, please. So, what is a healthy BMI range? So, BMI is the body mass index, which is the ratio of your weight to your height squared. If you could type in the chat, please. So that's 18 to 25. Lucy, I'm not sure if you're a dietitian. Um, any more? Yeah. So according to the WHO classification, it's 18.5 to 24.9. Um, just a bit of around BMI is very widely used within nutritional assessment or screening tools. However, BMI is a very quick indicator to see if a patient is underweight or overweight. It doesn't tell you any more around body composition. So say, for example, an athlete could have a BMI of 30, which would be overweight, but it doesn't take into account that a professional athlete would have a lot of muscle, and the BMI is higher. So the athlete isn't unhealthy or overweight, but it doesn't, what I'm trying to say, it doesn't take into account the body composition. So I think BMI may be a good indicator, but the context of it is also quite important. Because, say, for example, certain individuals from certain ethnicities could be naturally small most of their lives, and their BMI could be on the lower side, but that doesn't mean that that is unhealthy for them. So it's kind of the context of the BMI is quite important as well, rather than using it as a standalone. Yeah, if we move on to the next slide, thank you. So, nutrition. Why does nutrition really matter? So, eating and drinking are not simply essential for maintaining nutrition hydration, but they are also, it is also important for our social interactions and for pleasure. Food and meal times are a way we connect with others, and quite often they are also an expression of our cultural diversity. So, as long as a person or the individual is able to eat and drink and wishes to do so and gets pleasure out of it, then there is no need for intervention. However, when they are not able to eat and drink and unable to meet their nutritional requirements, then they might not get the specific nutrients or some or all of the nutrients they need to maintain health and a healthy body. So that's when we refer to the term malnutrition, which many of you may have come across. So if we look at malnutrition, malnutrition is often defined as a state of nutrition in which a deficiency or an excess of energy, protein, and other nutrients causes measurable adverse effects that is on your body and also has an impact on the functional and the clinical outcome. So when we refer to the term malnutrition, it takes into account the overnutrition and the undernutrition. However, for the purpose of this presentation, when I say malnutrition, I'm often referring to it as undernutrition. Okay, if we could move on to the next one. So the prevalence of malnutrition then. So the British Association of Enteral and Parental Nutrition, along with the UK Malnutrition Awareness Week, carried out a survey in the month of November 2023, and the overall prevalence of malnutrition, that is within hospital and community settings, was around 48%, and that in hospital was around 69%, which is significantly high, and of which about 40% had a primary diagnosis of neurological conditions. So that gives you an idea of the prevalence of malnutrition across the country, basically. Yeah. So various factors can contribute to malnutrition, and we can broadly classify them within social, physical, and medical. And if we could have, yeah, thanks, Kate. So if we could have the physical and the medical as well, please. It's a little bit of a busier slide, so I'll just give you a couple of seconds to read rather than me reading it out loud. So if we look at the medical factors that contribute, so anything or any conditions that increase nutritional requirements, neurological conditions are one of them, will have an impact. Conditions which impact on the body's ability to absorb or utilize nutrients, any mental health conditions such as eating disorders, conditions causing a lack of appetite, dementia, dysphagia. The list is quite long, but these are kind of the main ones. So all of these factors will contribute to malnutrition. Yeah. So the consequences of malnutrition then, the most obvious one is weight loss, which is predominantly fat and muscle. So when we say a loss of muscle or weight loss, which is predominantly muscle, it not only impacts on the mobility, but it also impacts on your respiratory function, increasing the risk of chest infections. It also impacts on your cardiac function, etc. So it's kind of the impact of it, the consequence of it is across the system. So it impacts on increased mortality. It also associated with increased risk of fall, susceptibility to infection, increased length of stay in hospital, impaired synthesis of new protein. So it could lead to poor wound healing, delayed recovery, and not to mention the increased healthcare use and the economic costs, and also the psychological impairment that comes with the effects of malnutrition. Um, so, why does nutrition actually matter in brain injury? So, brain injury can have a lasting and profound effect on the patient's physical and cognitive functioning, and all of this will have an impact on nutrition provision. Neurological conditions, as I said before, will increase the body's metabolic demands, thus increasing the nutritional requirements. And this is primarily due to the counter-regulatory hormones that the outpouring of these counter-regulatory hormones, hypercatabolism, increased metabolic rate, and lots of other reasons. And quite often in the initial days of the injury, or days or even months of the injury, you can minimize the impact of all these counter-regulatory hormones, but you cannot completely prevent it. When patients are in ICU, they could lose something like 2% of their muscle mass per day. So when a patient has a long ITU stay, they've already had a lot of loss of the muscle mass during their ITU stay, in spite of being fed to their nutritional requirements sometimes. So usually larger the loss of weight or larger the loss of muscle mass, the more severe is the malnutrition. However, an important point might be that some patients may have the BMI within the normal range despite the weight loss, because it depends what their initial BMI was, but you would have to consider what the muscle mass, what the loss of the muscle mass has been, in spite of the BMI being within the normal range. So that's quite a key thing there. So nutrition plays an important role in promoting recovery, rehabilitation, and quality of life. Okay, if we could move to the next slide. So if neurological intake remains suboptimal over a prolonged period of time, this will lead to poor neurological and functional outcomes. If patients are malnourished at the time of their brain injury when they get admitted to hospital, this will increase the dependency rates, healthcare costs, length of stay, pressure sores, infections, and the risk of mortality as well. So, having looked at some of these things, let's just look at a case study to put things into context. So, we have Mr. S, who has been transferred from ICU. He is a 23-year-old man and has had a road traffic collision. He's had a subarachnoid hemorrhage, multiple fractures, multiple injuries, including lung contusions and liver laceration. He's nil by mouth, NG fed, and he's had a long ITU stay. Now, what are your initial thoughts and concerns at this point? Oh, actually, and by the way, his weight is 55.3 kilos. He's 6'1", which is 8.5 meters, and his BMI is 16.1. So if you would just like to type your thoughts, initial thoughts or concerns at this point in the chat, that would be great. Yeah, he's underweight. Yes, so he's already underweight. He's malnourished at this point. Yes, because he's had a long ITU stay, so potentially he's lost a lot of muscle mass. Yeah. Anything else? He's NG fed. He's nil by mouth. Yeah. He's in a catabolic state post-injury. Absolutely. Yeah. So hold these thoughts and we'll come back to him as we move along. Okay. So malnutrition after severe traumatic brain injury. So about 68% of patients with severe TBI will be malnourished, and the percent of weight loss within the first 2 months usually varies between, Kit, if we could have the next click, please. Yeah, the weight loss would be around 10 to 29% during the first 2 months roughly. So if you think of Mr. S, he's possibly had quite a significant amount of weight loss already. Yeah, so if we move on to the next slide. So what are the nutritional implications of brain injury? We'll look at that shortly. But if you would like to just type in the chat, what could be the possible implications of brain injury? Fatigue, yeah. Weakness, unable to take part in active rehab, yeah. So that could be physical things, isn't it? Lack of interest, yes. Loss of energy from not getting adequate amounts or just demands being too high. Cognitive deficits, yeah. Sense of taste change, absolutely spot on, yeah. All of this is true. So we'll look at all of them one after the other. So first and foremost is the ability to swallow, which is dysphagia. I'm going to touch on dysphagia very briefly because Claire McLean, the speech and language therapist working with NRC, has done a whole webinar on eating, drinking, and swallowing difficulties. So highly recommend you refer to that. But just from a dietetic perspective, not only the difficulty with eating and drinking will have an impact on the nutritional implication, will have nutritional implications, but also the ability to visualize and recognize food, maintain adequate posture of the head, neck, and the body, tongue movement, lip movement, reflexes from the tongue, bite reflex, and ability to concentrate. Somebody said fatigue in the chat. So absolutely, eating is quite a slow and tiring process, which in itself causes even more fatigue. One of the patients one time said that eating in itself is like doing a gruesome exercise or exercise routine at the gym, which is so right because it was so exhausting just having a meal. It takes a lot of time to consume a meal, and by the time the patient's had half the meal, it has gone possibly cold, so it puts you off. If they've had an episode of near choking or a choking episode, that creates a lot of anxiety with eating as well. And not to underestimate the impact from embarrassment, the vulnerability, and the loss of enjoyment from eating. Because if we look at how many of our social interactions are around eating, and if you are having all these issues around eating, you wouldn't, it takes the joy away from it. So dysphagia is a very common consequence of many types of brain injury. So we see this quite a lot. So any loss in swallowing ability is likely to compromise the nutritional intake. This is in terms of insufficient consumption of food and fluids causing energy and nutrient deficits, limited choices. It depends on how the food is presented. So a lot of it, and it also depends on the texture modification that is required. Certain textures will have limited choices compared to others. So yes, it will impact. And also the losses. So if the patients manage half a meal of, say, a level 4, which is a puree texture diet, but they have lost a lot anteriorly from the mouth as a result of drooling or leakage, then they haven't really managed half. A quarter of it is almost lost. So although on the food chart, when you're assessing, you'll see half a meal consumed, but you have to take into account the losses as well. So physiologically, inadequate intake of food will lead to undernutrition and risk of dehydration. So all the things that we looked at, that the consequences of malnutrition, you'll still see with the person who has dysphagia. So this is further compounded by concurrent further illnesses and frailty, other comorbidities such as COPD, lung diseases, and other comorbidities, ill-fitting or absent dentures, and difficulty with positioning. And I would also say staffing is a huge impact as well, because when there is not enough staff to feed patients on time, or then the food has gone cold, or it's not looking as appealing. So if the carer or the person who's feeding the patient has made a passing comment on anything, that's going to impact the patient on how they take the food. So there's lots of factors which is further compounded if the patient's got dysphagia, so it's taking all that into account as well. um, Okay, so the effects on perception and cognition. Somebody said cognition, cognitive deficit. Sonia, I think, said cognitive deficits, which is absolutely correct. So impaired visual perception. Patients may not, or individuals may not recognize faces, objects, or foods on the plate. Spatial perception, they might not know where they are in terms of relation to the objects around them. So to figure out um, the spoon from the plate to the mouth might be quite difficult. Or if they present with neglect, they might just eat half their plate and completely neglect the other side. And impaired planning and sequencing. If everything's laid out in front of them, they might have the physical ability, but they might have a dessert before they have their soup and things like that. So all of this will impact on their nutritional intake. Um, and then if we look at the physical ability to eat, so that is ataxia, which is the tremors or the shakiness, and apraxia, which is often characterized by disordered purposeful movements, all of which is impaired motor control, could impact on the intake, how they manage their drinks. All these presentations will need individuals to have close monitoring, supervision, and assistance at meal times. And that in itself will have a huge bearing on the individuals, because it's the loss of independence, dignity, etc. as well. Presence of hemiplegia as well makes it quite difficult to manipulate food with one hand. And quite often you will see that the paralysis of the side of the limbs, they might have muscle wasting in that side, or there could be edema just from um, poor positioning. And all of this will increase their nutritional requirements because the efficiency of the movement is quite impaired. So if they're trying to use that limb, then it's quite effortful. So this will impact on their nutritional status and the requirements for increased energy. Um, yeah. If we then look at the eating behaviors, so quite often following a brain injury, especially if the injury is to their frontal lobe, then individuals can present with quite challenging behaviors, some antisocial behaviors. They could have poor table manners. Individuals could spit food, throw food, which makes it quite challenging at meal times. They could be quite aggressive as well and disinhibited. So that will have an impact on the oral intake. Mood changes could be a result of the medications, or it could be the result of the brain injury itself, and that can lead to undereating or overeating, because food is quite associated, and this is kind of has wider implications. You see it in weight management patients as well, sometimes, that how it links to the emotions in their childhood, etc. But from a brain injury perspective, this can lead to underfeeding or overfeeding. Effects on the appetite. So, say if there is an injury to the hypothalamus, then it can impact on their feeling of satiety. They might not have the feeling of satiety, and it can lead to hyperphagia. To hyperphagia meaning eating lots of food at a time. Um, and they could have hyperphagia for a particular food or just hyperphagia in general. And quite often, some drugs which are used following a brain injury can also have an impact on the appetite. So it's just to be mindful of that. Changes to smell and taste, and somebody mentioned in the chat as well, changes to smell and taste. I think Suzanne, it was. Um, which is absolutely true. Having had COVID, many of us, uh, we can realize the impact of what smell and taste will have, what impact it will have on our oral intake, because smell and taste are quite closely linked. So it's not just following a brain injury, it can either alter that change. It can alter the smell and taste, which could be partially lost or completely lost. So they could develop aversions to certain food, or what likes and dislikes they had prior to the injury almost become irrelevant, and they develop new aversions, or depending on what they like or dislike now. But then again, this will not only impact on their appetite, it will also impact on their quality of life, on their emotional well-being, personal hygiene, and safety as well. So changes to the smell and taste has wider implications as well. If we move on to the next slide. So then coming on to effects on memory. So some patients may forget that they've had a meal and ask for another breakfast or another lunch. And this can become quite behavioral sometimes, because they've forgotten that they've had a meal. And sometimes they can forget to have a meal at all. So you can see both, you can have both, depending on the individual. They may not remember what foods look like or what's in front of them. They might not know what cutlery to use, etc. Effects on the ability to communicate. So I'm only briefly touching on this, because if they have dysphagia, which could be expressive or receptive, so they might not be able to express that they are hungry, they're thirsty, or in pain. Um, which will have an impact on their oral intake. But also receptively, if they can't understand, if somebody is reading out to them or mentioning to the individual that would you like to have this or this for your meal this evening, they might not be able to comprehend. So it's not, they're just not going to be able to make that choice for themselves, in which case then we involve the carers or the family and try and do the best choices we can, and lots of trial and error, and lots joint working with the speech and language and nursing staff, but also taking into account what strategies can be used to help the patient to make those choices, etc. Sometimes even using picture menus doesn't work because they're not able to um, comprehend the pictures even. But I think as they go through rehab and working through jointly with the speech and language, we kind of tend to progress with that. Um, Claire again has done a whole webinar on communication, so highly recommend you refer to that if you would like to know more. And then moving on to the psychological effects. So awareness of the nature of the injury and the prospect of permanent or progressive disability is likely to be followed by an emotional reaction. And that's quite similar to that you would possibly see when there's a bereavement, and it may include shock, emotional lability, depression, and realization. And maybe this may result in further depression. Patients may be aware of their extent of injury, and they might become quite frustrated and resentful and be quite angry, really, and irritable with their carers, staff, and even healthcare professionals. Or they might just be unable to cope with the stressful situation they are in and become quite withdrawn. And as mentioned previously, if they are quite embarrassed to eat, because of the difficulties they have with the motor side of things, or even because they need assistance for feeding, they might prefer to eat on their own rather than in a social setting. And as a result, the individual as well as the families can become quite socially isolated. So, not to underestimate the social isolation that it can bring with all these difficulties. Yeah, so if we could go on to the next slide. So from a nutrition assessment point of view, a dietitian will do a lot of, a neuro rehab dietitian will do a lot of information gathering about all the things that we've just looked at. So dietitian will look at the anthropometry, look at other anthropometric measures such as hand grip strength, calf circumference, etc. And also there's a lot of liaison that goes on with members of the MDT. Dietitian will also look at the biochemistry, bowel, skin integrity, etc. So dietitian will, there's a few members of the MDT that I mentioned here, but that is not, there's lots of liaison that goes on, but I'll just kind of mention a few here. We could have joint sessions with the speech and language in terms of texture modification, what products we could use, or how we could fortify foods at an appropriate texture to provide the best nutrition we can, and make use of those muscles if they are on any tasters, and just encourage oral intake to reduce the reliance on the tube, and also the same for fluid intake, and also have joint working with the speech and language if there's any decision making around tube insertions, etc. So from a communication aspect as well. Dietitian will also liaise with the food service or the catering division, making sure that the food is presented, it's adequate, and it's also fortified to an extent so that not necessarily the patient has to eat huge amounts, but within the amounts they eat, we maximize the calories and the protein and the nutrients. Um, with the occupational therapist in the assessment and the management of the physical, environmental, and the cognitive function, use of adapted cutlery, mats, we've used different tapes, different slings, fairy lights, you name it. OTs are fantastic in terms of that. So yes, we do lots of joint sessions with the OTs to manage that and maximize nutrition intake. With the neuropsychologists in terms of any behavioral or psychological aspects impacting on their nutritional intake, or if they have any mental health conditions, or even in terms of low mood, depression, etc. Yes, there's quite useful input from the working with the psychologists. Nursing staff, in terms of weekly monitoring of their weights, food charts, implementation of the dietetic care plan, specific support around their management of boluses, be it bowel, skin integrity, management of their tubes or the tube care, etc. So nursing staff are almost like your ears and eyes, and you need really good communication with the nursing staff to get all the information and the first hand, because they spend a lot of time with the patients. Then moving on to the patients and family, obviously this is working very closely with the patients and their family, involving them in the goal planning, goal setting, and appropriate decision making along the way, and forward planning as well. Then with the consultant and the pharmacist, quite often there's lots of liaison with the consultants in terms of if the patient has gastrointestinal symptoms, as in terms of diarrhea, vomiting, reflux, to do with secretion management, to do with they're on lots of medications, and quite often we end up in polypharmacy because the medicines counteract each other, and then it has an impact on the nutrition in terms of constipation or diarrhea, or in terms of gastric motility. So it's rationalizing the medications, working with the pharmacists in going with the best kind of approach of how we go about things. Yeah. And then with the physiotherapist in terms of any respiratory kind of uh, support that is needed in terms of trachea management, secretion management, how it's impacting if they're having some reflux, etc., and positioning. And also from a spasticity point of view, because if they are quite fatigued and not engaging in therapy sessions, then quite often speaking to the physiotherapist is quite useful, I've found in my experience. Okay, so if we come back to Mr. S, he is on the acute ward. So his weight now from 55 kilos has dropped further to 54 kilos. His BMI is 15.8, and he has a peg tube in situ now, and mum has reported that his pre-morbid weight was around 78 kilos. He was very sportive and active previously. He's fed through the peg, and he's just commenced on tasters with the speech and language therapist. However, he's had a couple of episodes of storming on the ward. So if we would like to just type in the chat what your thoughts are at this point in time about Mr. S, please. Thank you. Yeah, so storming is an autonomic dysfunction, really, where you have an increase in heart rate, increase in temperature, increase in metabolic rate, profuse sweating, increase in muscle tone. And it's almost like running 4 or 5 marathons. So depending on how long the storming episodes is, but it is an intense episode, basically. Any thoughts from anybody? So if you think in terms of his nutrition, his weight has lost further. So far, now that we've had his previous weight, he's lost about 30.7%. He's had a weight loss of around 31%. So from a physio perspective, I would imagine he's limited in how much therapy he can participate in. Yes, that's absolutely right, Michelle. Yeah. So our main concern at this point would be storming possibly happening as he isn't hitting all his nutritional needs. Mm, it is quite kind of centrally regulated. So maybe I can't really say that for sure. But storming will definitely put huge demands from a nutritional perspective, from a calories and protein and a fluid requirement. So if we, from my experience, when we've had patients with storming, we would push through 3,000 plus calories and over 3.5 liters of fluids. It is quite scary of how much we push into the patient, physically possible to push through the tube, as in, because you can only run the rate of feed so high because they're not going to tolerate very fast rates. So it is quite a challenge to get all the nutrition they need within the space of time. But then you're not going to feed for the full 24 hours all the time for days on end. So yes, it definitely puts a lot of nutrition demands depending on how many episodes they are having. Okay, so if we keep Mr. S in our heads, and then we'll come back to him again. So far he's had about 30%, 30 to 31% weight loss. He's having difficulties on the acute ward with storming, and obviously also thinking of the interruptions within the feeds that they have on the acute ward, which is relating to, they're going for scans, investigations, or any further surgeries, etc. So a lot of the times they don't get the full amount of feed as recommended as well. So, along with all the things that we have discussed already, a dietitian will also consider, we've also already talked about autonomic storming, but looking at the fluid requirements and the dehydration, because a lot of the brain injury patients will need far more than the recommended is 30 to 35 mils of fluids per kilo of body weight. But in practice, most of the brain injury patients will need far more than that. For various reasons, because of if there is an impairment in their temperature regulation, or because of excess secretions from their tracheae, or hypersalivation, or just from drooling. And if they have diarrhea. So all of this will contribute to increased fluid requirements. Post-traumatic amnesia, or PTA, which is particularly characterized by impairment in their memory, or some may include some psychological symptoms as well, which could be aggression, or disinhibition, or anxiety, or agitation, distress, and behavioral issues. And it makes feeding the patient quite challenging, because a lot of the times, and I can think of various patients in my head right now, some of them are walking, talking, and they just walk around the ward, or, in the setting they are, and the amount of calories they just use from walking around is quite hard to keep up with, and they're unable to sit and eat. So we almost kind of have to resort to finger foods and just fortify the foods and work with the patient and the family to get them. And thankfully, a couple of patients who were pretty bad with their PTA were on normal diet, normal fluids. Otherwise, it's even more challenging if they are on a texture modified diet. So, liaising with the OT, psychologists, and speech and language is quite key when you have patients with PTA. Hypopituitarism, again, is quite common with the brain injury patients, which will have an impact on the metabolic rate and the nutritional requirements. Pre-existing comorbidities, obviously, if they have diabetes, managing the blood glucose, because it could also be stress induced sometimes. So they didn't have diabetes pre-morbidly, but they could have diabetes as a new diagnosis. They could have pre-existing liver conditions, or CKD, chronic kidney disease, or IBS, etc., which will again impact on their nutritional requirements and nutritional management. Quite often, you'll also see sodium imbalances, which is particularly SIADH, which is the syndrome of inappropriate antidiuretic hormone, where you may have to have fluid restriction and have a low volume feed, concentrated feed, basically, because of the fluid restriction. Or you could have cerebral salt wasting, or you could have diabetes insipidus. Um, so you'll need to manipulate the fluids then. Spasticity again is will increase the energy requirements quite massively. So quite often the dietitian, when he or she is doing the nutritional assessment, will use certain equations to calculate the estimated nutritional requirements, but it does not take into account the spasticity side of things, the formulas or equations. So although you may feel that you are feeding the patient to their requirements, but they still end up losing weight. And spasticity is quite a huge impact on the amount of calories they will use. So if the spasticity is quite high and not managed very well, then it will have a huge bearing on the nutritional requirements. Vestibular symptoms, any impairment to balance will kind of cause dizziness, motion sickness, and just generalized nausea and vomiting. Skin integrity is quite, most of the patients are at a risk of pressure sores, mainly because of immobilization and muscle wasting and difficulties with repositioning. So quite a lot of things, and it could be a combination of things, or yeah, it just depends on what the patient presents with, depending on the injury. If we could move on to the next slide, please. So carrying on with the other considerations is reflux, vomiting, diarrhea, and constipation. All these GI symptoms are quite common. Nausea and vomiting could be related to medications or changes in the intracranial pressure or any block to the shunt. So quite often the dietitian, if it's a new symptom, will mention it in MDTs or liaise with the consultant if it's a new symptom and they didn't have this before, to rule out any issues with the shunt or hydrocephalus or things like that. Or if they have a jejunal tube and if that's displaced and gone back into a stomach, that can also cause diarrhea and that can also cause vomiting. There could be other triggers such as movement, hoisting, suctioning, reflux. There's so many things which could cause this. So it's working closely with nursing staff, healthcare professionals within the MDT and getting accurate information. And dietitian should be able to kind of manipulate and try different things. Diarrhea often is medication related or use of lots of antibiotics within their acute stay. Again, there's lots of things which can be done to the feed, the supplements, etc., whatever the patient's on, to minimize diarrhea and protect the skin and prevent any moisture damage. Um, then looking at, yeah, so we've looked at pre-existing gastro conditions, exacerbation of pre-existing food behaviors, and other complications related to multiple trauma. So if they have any max fractures and things like that, that will again have an impact on their nutritional intake. Okay, if we could go on to the next slide. So quite often, when patients come into a neuro rehab setting, they come into a state of undernutrition, and this is primarily due to the catabolic effects of the initial injury. And quite often, enteral nutrition is commenced quite early enough with the improved trauma pathways, etc. And the initial nutritional priority is to restore nutritional status and maximize ability to participate in therapy sessions. That is the primary goal. So just getting enough calories, protein, and nutrients and establishing that stability is quite important. And as they progress through their rehabilitation journey, the objective gradually changes to help overcome or mitigate neurological difficulties affecting food intake and to ensure that the nutrition intake is adequate. And as they progress further, so they could have persisting disabilities, but further into their recovery, you kind of then go into preventing weight gain and overnutrition because they have got specialist equipment, specialist chair, and if they continue to put on weight. So in the through the pathway, you see quite extremes. You could have a patient who's quite underweight at the start of their journey, and by the end, they are at the end of their rehab journey. We are talking of preventing weight gain and overnutrition. And quite often, we'll have families who were desperate for their loved one to eat. And it's quite lovely to see them bringing in McDonald's and KFCs towards as they progress through their journey. But then again, it's that education, it's that monitoring, it's that review of giving the advice of what the implications are of further weight gain, etc. Um, so, if I had to summarize the nutritional management, the ultimate aim is to optimize nutritional intake in a way that maximizes the individual's rehab potential and quality of life. So, if we come back to Mr. S again, he's now in a neuro rehab unit. His weight has dropped even further to 53.5, and his BMI is 15.6. He continues to be peg fed. He has progressed to level 4 and level 1 fluids. So that's your purine diet and slightly thickened fluids. His intake orally is a bit poor, and he also has diarrhea. So at this point, the neuro rehab dietitian will, this is the starting weight because he's just transferred to the neuro rehab unit. And this is quite often the case that when they transfer from acute to rehab, they have lost huge amounts of weight. Um, they could be nil by mouth, or in Mr. S's case, he was on level 4 and level 1, not eating very much. But I think at that time, his main focus was diarrhea. That was really causing him a lot of bother, which is understandable. He was quite a young chap as well. And all it was that he'd had lots of antibiotics when he was in the acute for various reasons, understandably, and his gut microflora was absolutely washed out, if I may say that. Um, so we worked a lot on manipulation of the fiber, just trying different things, different products, and gradually it did settle down. We did rule out if he had any pancreatic insufficiency. Lots of stool samples were sent. He didn't have any infection. So you go through all of that to make sure there's nothing sinister underlying. But then obviously this is time consuming, but uh, at that point, that was his main focus, that he just wanted to have regular bowel movements. That was his main focus. Um, okay. So, across the spectrum of nutritional management, you could start with the patient, as in this case, he was nil by mouth, reliant on his enteral tube. Then they would move to a texture modified diet with fluids and enteral feeds as top up, or they would upgrade fully to eating or upgraded to oral diet and fluids, and the tube is only used for fluids, medications, and feed, or they could have a combination of everything. So you could have a patient kit, if we could have all of them, that's fine. Or you could have a combination of any of this. Not that the patients always progress in a linear fashion. Sometimes you take 5 steps forwards and 10 steps backwards, but you work with what you've got, and quite often you are able to make progress. So, depending on how long they've had their rehab and how long they've been within the unit, quite often we are able to progress them because rehab's quite goal oriented. So we work with realistic, setting smart goals and then work towards those. So you could have quite a mixture of any of this, um, to be honest. Yeah. So if we have Mr. S in mind, but then we look at what if he was 23 years old, but what if the patient was elderly and had multiple comorbidities? What would be the nutritional implications then? Or if the patient had poorly controlled diabetes and needed dialysis 3 times a week, what would be the nutritional implications then? And all these scenarios are based on real patients, so I haven't made it up, but we've kind of worked with these patients. So it just gives you an idea of what the nutritional challenges could be on top or alongside the brain injury. Patient could have a Crohn's disease and they could have had part of the bowel removed, so they could have a colostomy or an ileostomy, or they could have pancreatitis, which could be pre-existing, or it could be a new diagnosis. um, or what if the patient was pregnant? We had a young lady who came to the unit when she was 7 weeks pregnant. She couldn't have a peg inserted, so she was NG fed for a long time. But then she progressed. By the end of her, well, it was a planned C-section she was having. So by that time, she had progressed onto oral diet, but it was quite a challenging time for the dietitian as well as for the MDT to manage a lady who was in early kind of weeks of her pregnancy. But what if, that brings its own nutritional challenges? What if the patient has an eating disorder or a mental health condition? Or if they have pressure sores and poorly controlled diabetes, that will have, again, put extra demands on the nutrition. And how do we meet those requirements? So dietitian will take all this into consideration, but lots to think about for now. So it would be quite unfair if I didn't bring you back to Mr. S. We all like a closure. So at the time of his end on the rehab unit, his weight had gone up to 67.2 kilos. So when he came, he was around 55. His BMI is now 19.6, and he had progressed to a normal diet, normal fluids. He enjoys eating with his family. He was less reliant on the peg. I think the peg was mainly being used for some of his medications because he hadn't progressed to taking all his medications through mouth yet. He had started taking a few, but not all. And I think fluid intake was a challenge for him. He wasn't very good with drinking fluids before. So to now get him to change and drink more consistently, that's why I think, but eventually he would progress onto his peg removal. That's what I anticipated. He was decannulated and he was able to do his activities of daily living with assistance and supervision of one. And he had still ongoing rehab goals. So he was going to be transferred to a slow stream rehab setting. What, any thoughts, any comments on the progress he made? So essentially, he gained about 12 kilos whilst he was on the rehab unit. So his initial BMI was around 16, which dropped to 15, and then it went up to 19.6. So we did lots of anthropometric measurements around his muscles as well. So we do hand grip regularly, his scarf circumference, etc. So it was not just the weight he had put on, but he was also kind of improving in function, which is always reassuring. Um, Anybody like to make any comments or any thoughts they would like to share? Please put it in the chat. Okay, so if we progress on to, yes, it's a good outcome. So the key messages is brain injury can have a lasting and profound effect on the patient's physical and cognitive functioning, all of which will impact on nutrition provision. Nutrition should be an integral part of care, individually tailored and considered across the entire pathway. And long term monitoring and review is important, not just whilst in the hospital. And that brings us to the end, and we'll open up to questions, please. Thank you very much for listening.
Thank you so much, Vishwa. That was very, very interesting. I've certainly learned a lot. We've got one question in the chat from Melanie.
Okay.
So, who's asked, in routine care, do you measure gut microbiome after antibiotic treatment?
No, we don't routinely measure gut microbiome, but we kind of work that, we try and work so that we kind of increasing the microbiome so that it improves their gut flora.
Wonderful. So Vishwa, we're at 5 o'clock. That was absolutely
Yes.
fantastic. If anybody's got any questions they want to, they can absolutely email in our team. We'll pass those on to you. We will make the recording available for everybody. But no, thank you ever so much.
Thank you everyone for taking the time.